imaging biomarkers as guidance. We figured out how to introduce multiple drugs simultaneously. We have a common platform for sharing data, and we used a new type of design called adaptive trial, so you learn as you go. I'll talk about that in a minute. So one of the problems, what's that? Yeah. 2 words. Yep. So the neoadjuvant approach dramatically accelerates non-assurance, and the way it does that is that normally in the metastatic approach is where we introduce new drugs. And that happens in a 2 to 4 year knowledge assurance. It takes us about 4 or 5 years to figure out whether that drug works, and then we move it on to the adjuvant setting. And but the problem is people who have disease where it's spread to the other organs. That's what metastatic disease is. You can't cure them. So in order to test whether or not something's going to work, you have to bring it into the adjuvant setting. That means you do surgery, then you give chemotherapy, and then you add a new agent, and then you have to wait 5 years to see whether they recur. So that necessarily says that you're going to have to wait another 10 years. So now you've got 15 years to try and figure out if your drugs work. And it turns out that most of the drugs that you introduce from phase 2 and move them on to phase 3 in the setting, only about 30% of them work. So that's a very inefficient way to do things. So what we do in the I-SPY trials, we start with chemotherapy because we know we can identify these high-risk patients. We can do a mammoprint, and only patients with mammoprint poorest prognosis will go on the trial. There you see biomarkers in action now in a clinical trial setting. And we add the new drugs right away. We then learn at the time of surgery whether or not the tumor's gone away, and we confirm it with imaging. That brings us down to something like a 1-year knowledge term. So now that's a 10-fold improvement in the efficiency of learning about these patients. And since we know that all the patients aren't the same, every patient will have an array. Every patient will be categorized, so we'll know which drugs work for which patients. Noel's going to talk about imaging, but we can learn with imaging who's having a good response and who's not. I'm not going to go into that. And what we've done is we've figured out how to test many drugs at once. We got the companies to agree to put up their drugs in this trial all at the same time. And so, for example, a patient might be on study. We learn about whether or not the tumor is working. That information goes back into the pile and helps us determine whether the next patient should be randomized to that drug. We learn as we go, adaptive design. Instead of saying, oh, I think we need 300 patients, blind the trial, and then wait and see, that's sort of a silly and inefficient way to do it. Because if the drug isn't working as well as you think, you can stop it. If it's working better than you think, the next patient and the patient after that will get randomized to this trial, and you learn as you go. You might drop a drug because it's not effective, add a new one in, graduate something that's going to work, and you'll have drugs in the pipeline. So you've got this very efficient mode of doing that. So we have this. We have 5 drugs to start. I think that's it. And we actually have 20 sites around the country that are participating in this trial. And so this is an example of how you can take biomarkers and move them into the clinic. And now what you're going to hear about from Nola is really how we worked on getting the biomarkers, imaging, defined as a biomarker, and how we're using it to actually, and the whole process of standardizing the way people interpret it. It actually seems simple, but it's actually quite complicated. And what was great about it is now that we can introduce this into every site, and every site that's participating in this trial is going to have the biomarkers defined the way, using the tools that Noah's developed in I-SPY 1. And it is, when you're doing this kind of development, so to answer your question, how do you get it? You have to have a vision of where you're going, but you have to do the homework one step at a time to try and build the case. But with each new step, you want to add innovation and do things that really drive change. That, for all the people I think that required reading ought to be, there's a 2-page article that Andy Grove wrote on efficiencies in the healthcare industry. It's in JAMA, the Journal of the American Medical Association, 2005, I think. I'll look it up, 2005 and 2007. Anyone who's developing biomarkers should be reading that article. Because we have much to learn from the semiconductor industry about how they, if Google wants to test something, they'll have the data in 4 hours. We may not be able to get our data in 4 hours, but we need to be having that mentality that we don't have to wait 10 years, that we should be driving to figure out faster, better, quicker. And that it's actually, people think it's unsafe to be in a hurry, but it's unsafe to just do things as they are because people are dying. That was a good shot. Okay.
Do you want to take questions?
Why don't you go ahead with the imaging and then we'll
Okay. All right. Well, I really just wanted to give a really brief overview. If you have the course syllabus, you'll notice that there is actually an imaging session. We wanted to present a little bit about imaging here in the prognostics talk, because this concept of using imaging in a prognostic fashion is really sort of the new paradigm with imaging, the field of molecular imaging, functional imaging. A lot of what you hear that's exciting in imaging now is about using imaging in a way other than what has been the conventional, traditional way to try to look for disease by studying the presence and the shape and size of abnormalities. Now we're moving to something where you're taking your imaging tool and you're trying to make a biologic measurement. And then from the image, there's two aspects of that. It's the technology itself, the instrument, and how you're using it and whether you're able to obtain images from that. Then there's the issue of how you take the image and turn it into a quantity. What's the numerical value that you're going to use? And then, beyond that, are you going to use it and call it an assay of some kind? Now, clearly, the power of having something like that is that imaging can be non-invasive. You can do serial measurements. You don't have the sampling error that you get from pathology, so you're not just getting a portion of the tumor. One of the things we clearly know are that tumors are heterogeneous between patients, but also within the same tumor itself. That tumor can be very heterogeneous in its distribution and its biology. So we can perhaps capture that, and that's certainly the promise of molecular imaging, but we're not quite there yet. So just starting out, if we're thinking about what is an imaging biomarker, it's really a quantitative measurement of a biologic process is made from in vivo data, imaging data. And it should, if it is functioning as a biomarker, it should reflect a disease status, it should increase as the disease progresses, decrease as it regresses, and differentiate between states of disease. Now it has potential to be both prognostic and predictive, and those are things that we're really just starting to learn about imaging. So just as an overview, we use imaging in clinical practice routinely in breast cancer. So mammography, ultrasound, these are the conventional methods for screening, diagnosis, and staging. MRI is a newer technology. It's been adopted. It's been being disseminated, but really its role is still being debated. It's very sensitive. There's an American Cancer Society recommendation for using it now as a screening tool. We're using it in pre-surgical staging, but there's a lot of debate over its role, and with this idea that it is a very highly sensitive technique, and perhaps not everything that we're capturing is significant, as Laura's just talked about. And then there are other methods, including PET, optical. They're not used routinely in clinical practice, but so they're considered to be experimental, but they are being pursued. So thinking about this, these different types of approaches that can be quantitative and perhaps be used in a biomarker type fashion, there's digital X-ray. So we've moved from plain film X-ray now to digital X-ray. And that is full field digital mammography, which is the current convention now for performing mammograms. But there's also now instrumentation that's being developed for 3D acquisition of X-ray images of the breast. And so these are tomosynthesis and computed tomography, breast CT. Those instruments are under development and are being evaluated, but they're not clinically disseminated yet. And then within MRI, totally different physical phenomenon. So digital X-ray, you're using an X-ray source, you're looking at the transmission of X-rays through tissue. Magnetic resonance imaging is a fundamentally different property. You're looking at a different physics and mode of creating an image. There is not a path of a photon going through tissue. This is something that you use the body's natural magnetic susceptibility, and you elicit some response from tissue, and you use gradients, magnetic field gradients, to sort of spatially dissect the signal that you're capturing and put it in position in the image. So there's not a photon path in an MRI image. Within MRI,